Hello and good evening, everybody, and welcome to yet another Facebook Live. Firstly, I'd like to say thank you very much for joining us on what is such a lovely evening. I'm aware that it's very warm, so we do appreciate you taking time to join us this evening. I'm going to do just a little bit of housekeeping before I hand over to this evening's speakers. First and foremost, I'd like to thank Smith & Nephew for supporting another one of these events. And we're really looking forward to this evening. This evening's session is called Wound Care Shared, a win-win, and it's clinician attitudes to shared care and perceptions on the current extent of patient engagement in wound care. We have two absolutely fantastic speakers this evening. The first is Zena Moore. Zena is the chair in nursing, head of the School of Nursing and Midwifery, and director of the Skin, Wounds and Trauma Research Centre, Royal College of Surgeons in Ireland, University of Medicine and Health Sciences in Dublin in Ireland, which is quite the mouthful. So hello, Zena, are you there?
I'm here, Alec, thanks very much.
Hello, welcome. Thank you for joining us. I'm just going to quickly introduce then Heidi. So we're also joined tonight by Heidi Sandoz, who's the Tissue Viability Services Lead for Hertfordshire Community NHS Trust. And Heidi, I can see you. Are you there? Are you well?
I am, thank you, yes.
Excellent.
I feel like I'm doing Eurovision there.
Did you?
Yeah.
Okay, well, listen, I know that you two are absolutely eager to get on, and we've got a fantastic presentation that we're going to go through. So it just leaves me to say, as always, you can see that we're presenting from our homes. So if there's any technical difficulties this evening, please do bear with us. As always, certificates will be available at the end, along with any links for any documents that we mentioned throughout the presentation, and you'll be able to get copies of the slides from our website from tomorrow. Again, thank you very much to Smith & Nephew. Zena, Heidi, good luck. I'm going to hand over to you now, Zena, and I shall see you both after the presentation for the live Q&A. Good luck.
Thanks a million,
Thanks,
Alec.
Alec.
Thanks very much. Okay, so as Alec said, I'm Zena Moore and I'm from Dublin, Ireland, and it's a great pleasure to be here with you this evening. And as Alec said, thank you so much for taking the time, and thank you so much to Smith & Nephew for putting this event on, and also for giving me the opportunity to share this work, which is a collaborative effort you'll see from many people. So I'm going to share with you about clinicians' attitudes to shared care and perceptions on the current extent of patient engagement in wound care. And what I'd like to present to you is the background to why are we interested in this subject, the methods for this particular survey, the results, discussion, conclusion, and some acknowledgements. And just so you know, this document is available to you from Wounds International, so you can download this yourself and read the entire paper, which will just give you some supporting information as well. So what does involving people in their own care actually mean? Well, what it means is that it's supporting people to manage their own health and well-being on a daily basis. And you're supporting them to become involved. And the key thing is that it is as much as they want or are able to in decisions about their care. It's also giving people choice and control over the healthcare services that they receive. And I guess if that were you or me, that's something that we might both really think is very, very important, because sometimes people might feel that they don't actually have the choice and that they're just in a situation that they really might have said, if I known more about it, I might not do it this way. And also focusing on what matters to the individual within the context of their lives, not just simply addressing a list of conditions or symptoms to be treated. And I think here's a good time to really reflect on that, because everybody who comes to you for care and who puts themselves in your hands for care really comes with they're a whole being. So they come with many, many facets, and it's not just the particular problem that they have. So it really is important for us to consider this in the context of the whole person or the whole being. And then I suppose when we think about what happens when we don't actually involve people, what happens is that it results in distress. Now, they're already distressed because they have a problem, an illness that they've come to you to take care of, a wound that they want you to look after and to help them. And now they're distressed because you don't involve them in this at all. And that can result in a loss of trust or confidence. And if you yourself don't have trust or confidence, for example, in your GP or your healthcare practitioner, can you imagine then what it's like to actually have to go and ask for care from that person or ask for advice? And what can often happen is that because there's distress and this lack of trust or confidence, because they don't really believe what the health practitioner is saying to them, then that may result in a lack of compliance. And compliance is often something we think about in terms of I ask the patient to do something, the patient won't do it, and therefore they're non-compliant. When oftentimes what really may be the problem is that I haven't listened to the patient and I haven't asked them what they particularly want from this circumstance. And as a result of that, I'm not hearing them. And I may be prescribing something for care for them that really doesn't suit their lifestyles or their home environment or whatever. And so lack of compliance isn't simply just a black and white thing. It really has a lot for us to think about. And if I don't trust or I don't have confidence in my healthcare providers, it's highly unlikely that I'm going to access that service as regularly as I should do. And clearly, when we bring all of this together, a distress, lack of trust and confidence, not really doing what I'm supposed to be doing, and not accessing services the way I should do, clearly my health and quality of life is going to have an adverse effect as a result of that, because I'm not really getting the optimal care for the problem that I have. So here's a really interesting study by Suzanne Kapp and Nick Santamaria from Australia. And they were exploring how and why patients self-treat their chronic wounds. The average age was 64.6 years in this particular study, and 50% of them were female and 80% had a lower leg wound. And the two most common reasons for self-treating were that they wanted to be independent and they wanted to do the treatment at a time that suited. And if you reflect on that, if you were waiting for a healthcare practitioner to come to your home to do your dressing, but actually you wanted to have a shower 2 hours ago, or you want to have a shower in the evening, or a bath, or whatever it is that suits you, or because you wanted to go out, can you imagine then the impact that that's having on your activities of daily living? So these seem very realistic reasons why somebody would like to self-treat, providing that they're able to do so. And what I find really interesting about the study is that only 22% were supervised regularly for wound care. So maybe I'm agreeing that, yes, I can be involved in my care, I can share the care for my own wound, but you're not really checking to see whether I'm actually doing it the right way or whatever. And also that only 6% had received education and training to support their self-treatment. And we'll come back to why this is really important later on. But just think about it, like when any one of us were being taught about managing somebody's wound, we received education and training to do that. And why do we think that if a patient is going to self-care or share in their care, that they shouldn't actually also receive education and training in order to be able to do this? But what Suzanne and Nick found was that self-treatment actually improved the individual's physical well-being, because they felt that they had better pain management, because say if the dressing was annoying them or whatever, they had the opportunity of changing that themselves at a time that suited them because they were uncomfortable. And they also felt that wound healing was enhanced, and that could be because of an increased self-related quality of life, which in itself can enhance wound healing. But also because their emotional well-being improved, because it helped the individual to manage the worry about infection and dissatisfaction with professional care, because they felt, look, I'm doing this myself. I'm going to be able to recognize when there are problems with infection, and I'm going to know when to call somebody. And also that I won't have to interact with the professionals as much as I normally have to, because I'm managing this quite well myself. And it also lessened the social consequences of the wound, because they were able to create an acceptable appearance. So rather than for example, if it was my leg ulcer, me having to accept exactly what you're saying I'm going to have as the treatment, perhaps because we're sharing the care, now I might say, well, rather than having a compression bandage, I would rather wear a compression stocking so that I'm able to shower and bathe more frequently. And that way then I'm able to create an acceptable appearance, because to me, my leg looks better in a stocking than it does in a bandage. They're able to maintain their lifestyle, as I explained earlier, because they're able to get on with activities as they wish to, when they wish to. And they can also minimize the time receiving professional care, and that's important for people too. And never forget the reduced financial cost of dressings and expense associated with professional care. Not everybody gets this for free. Many people have to pay for this care themselves. So therefore, if they're actually doing better, choosing the dressings that are suiting them and are doing well, then that will have a reduced financial impact on them. So let's take a look at the survey itself. So the aim was to explore clinicians' attitudes in terms of the current levels of patient engagement and also their attitudes to patient engagement in terms of wound care. So there was qualitative and quantitative methodology. The respondents were recruited from a specialist healthcare panel, included nurses, wound care nurses or GPs, who regularly treat chronic wounds in a community setting. It was a 1-hour interview and the fieldwork was conducted between November and December in 2020. So let's have a look at the quantitative results here. So there were 511 interviews and you can see the spread of countries: Australia, China, France, Germany, Spain, UK and USA. And then 28 qualitative interviews were conducted. You could see an even distribution: France, Germany, the UK and the USA. So the results show that 42% were either very positive or extremely positive about the concept of patient engagement. And 60% agreed or strongly agreed that patient involvement is beneficial for patients who can participate in shared care. And they estimated that 45% of their patients with chronic wounds could actually benefit from greater involvement in their own care. So quite a positive attitude towards it, and estimating that there was, yes, a genuine need for this in terms of the patients that they were looking after. And they talked about the benefits to the patients. And like what you saw with Suzanne Kapp and Nick Santamaria, they found that independence was going to be a benefit to the patient because the patients are more in control of their own times, as we discussed. They thought that there would be benefits to the patient in terms of increased compliance, that patients are more likely to comply when they are a part of the decision making, and this is borne out in the international literature as well. And privacy, which is probably something that you and I don't think of often, that there would be a reduction of healthcare professionals entering their home, so the patient wouldn't have to feel, oh, I must have my home spick and span before the healthcare professional is coming in, that they could just relax a little bit and know that they were not going to be visited by the healthcare professional so often. And also they felt that the patient's attitude may change in that they may feel more positive and empowered and enthusiastic about their care, because feeling that themselves that they are making this active contribution towards their own care for their wounds. And also that they felt, from the point of view, if we were benefiting the patient, that also that they themselves as clinicians, because the patients were using up more of the time themselves, that the clinician themselves would have more time available to treat those who can't self-care or share their care. That there would be a cost reduction if there were fewer visits and better outcomes, depending on the model for reimbursement that's in place. And that they felt that they would have a stronger relationship with the patient if the patient was more involved in their care. And also, which is a really key important factor, is that there would be better reporting of the symptoms, so that if the patient were more knowledgeable and aware of symptoms to report, that they would actually be more quick to call the healthcare practitioner for help, because they know what they're looking for and they recognise when things are changing adversely for themselves as the patient. But if we look at the extent of patient involvement, and if you look at this particular figure here, so the darker colour is the fully involved. The patient feels confident and is capable of monitoring and managing the wound on a daily basis. So if you look at this, for example, from the total population, 26% felt that their patients would be fully involved. That extended from 34% in China to 17% in France. And if we look at the next colour, which talks about shared involvement, and this is where the patient and the clinician have equal responsibility for the monitoring and management of their wounds. And once again, 34% of the total population felt that this would be the case, extending from 43% in China, 36% in Spain, 34% in Australia to 24% in France. And then the last colour is looking at the not involved, where the patient is passive or unable to take on responsibility of a wound and relies on others to make the decision about care. and 40% from the total population, and it goes from 23% in China, 43% in Australia, to 59% in France. So even though the clinicians have a positive attitude towards the concept of shared care, when they were asked to actually think about the extent of patient involvement in their own countries, you can see how this involvement extends from not involved to fully involved and varies depending on the country that you're looking at. So when the clinicians then were asked to think about drawbacks, they were thinking about drawbacks for the patients. And one of them, which is an important concept to think about, is the lack of reassurance. Because as we know, when we go through the stages of change, we might be at a point whereby we are actively involved, but then something happens and we may go further back down the stages of change to whereby we're saying, look, I really can't do this. And what we need is the reassurance from our healthcare practitioners in order to be able to say, yes, you are on the right track. Yes, you're doing well. Or look, here's some little adjustments that you need to make. And that gets them back on the horse, as it were, in terms of saying, look, yes, you're doing good. Keep going. You're doing very, very well. So that reassurance is fundamentally important for people who have chronic problems, as we see in dermatology, as you see in weight management programs. All of these are really, really important in order to keep people on the right track, as it were. They felt that clinicians felt that there was a risk that there might be an increased likelihood of wound deterioration. So what they meant by that was that if the person didn't really know what to look out for, that their wound may be deteriorating and they wouldn't recognise it and wouldn't have told the healthcare practitioner. And also that some people may have a lack of expertise. So we can't assume that they would have the skills and knowledge to be able to do this shared care themselves. And you know that isolation can be a problem because if, for example, the healthcare practitioner is the only visit that patient is getting on a daily basis or a weekly basis or bi-weekly or more often, then when nobody is visiting them, that could lead to isolation. And we see the concept in the Lindsay Leg Clubs where they really value the importance of making sure people don't feel isolated, so that those that have healed leg ulcers become involved with the Lindsay Leg Club, maybe, doing the registrations or maybe doing the, making the tea or whatever, helping them to keep involved so that they don't feel that they need to have a wound to be involved, that they can be involved in other ways. So it's important for us not to forget that concept and to bear it in mind if we're thinking about patients of ours that might need, benefit from shared care. So the other drawback they felt was that there could be an issue in terms of timing for actually assessing and determining which patients are suitable. And also, how would the clinician know how to assess somebody in order to determine their suitability for the concept of shared care? They felt that, and you know that yourself, that when you're interacting with patients, it's never just about the particular problem they have. You're gathering a lot of information about the person. Like, so for example, if I'm normally coming into you smiling and fairly happy, and I come into you today feeling, showing that I'm sad or low, that you would be able to recognize that and be able to say, is something going on there today, Zena? Have you got a problem really? And therefore you have the opportunity of kind of assessing lots of different things, not just the patient's wound itself. So the clinicians felt that not engaging with the patients as often may mean that they miss holistic issues that are of importance in terms of the patient's health and well-being. There was also the question about who is responsible. So if I am handing over care in a shared manner with my patient, where does the responsibility for that lie? And that's something that people need to think about in terms of where they're working, the different regulations that may be there. But it is something for us to think about. And also that there may be a negative emotional impact, because even for the clinician, it might feel, I'm not giving as much care as I normally do to the patient, and I feel bad about that. Or that the patient may feel, I've lost my relationship with my clinician, and that could be a problem. And also for the clinician, there is the risk of loss of income, because in some jurisdictions, the healthcare practitioner may be paid per visit. So the less visits I have, the less income I have. And that is a problem for clinicians. But nonetheless, so what we've seen so far is that clinicians themselves have a positive attitude to it. that there are varying degrees in which they feel that their patients are involved, from fully involved to not involved, that there are advantages to the patient and to the clinicians, but that there are also drawbacks. But nonetheless, it does bring us back to the concept of why would we want to be involved in delivering shared care with our patients? And one of the reasons is because health happens outside of the examination room. So if you are visiting me in my home or I'm visiting you in your clinic, most of what happens to me in my life happens to me outside of that actual engagement that we've had. So there's a lot that I, as the patient, has to do in order to be able to maximize my health outputs. So that's why we agree that health happens outside the examination room. We know, and you and I know this, that patients are more than their illness. That you and I, if we're ill, bring a huge amount of other variables with us that confound what's happening in terms of our wound. And therefore, we need to think about it in the concept of the whole patient. And I think a really important insight is that patients do have valuable insights into their own healthcare experience. So oftentimes they know more about their problems from their own perspective than you and I do. And failing to engage them in understanding that really means that we're missing a really important trick with regard to the patient themselves. So how do we support greater patient engagement? Well, I think when you look at the work of Suzanne Kapp and Nick Santamaria and the results of the survey here, feedback from the patients themselves really stresses to us the importance of optimizing communication with the patient. Now, time is always the issue, but it's like anything. When we do something right and take the time at the outset, it does mean that we can really yield the benefits as time moves on. Because if we can establish this at the outset, understanding about the patient, communicating well, we really will get the true picture. In order to identify people, we need to be able to understand where patients sit on a continuum of self-care or shared care, just as you saw in the survey results, going from completely independent to not actually able to manage myself at all. But the key thing is that depending on what's happening with the patient, they may move through the continuum. So they might move from not involved to partially involved to fully involved, and moving back if something else should happen to them. So it's important for us to be able to identify the right patient and where they are on the self-care continuum. And what we need are tools to encourage and support patient engagement. So it becomes like a mantra for us that this is an opportunity, this is a possibility, but I do need tools and checklists in order that I can assess the right patient, to choose the right patient for the right part of the self-care continuum at the right time for the patient. So all of these are ways in which we can support greater patient engagement. So fundamentally, patient engagement is an important concept, and we can see that from the international literature as well, that patients want to play a more role in their own healthcare. And that the key thing is that shared care doesn't mean less care for the patient. It means a model whereby we are here in it together, and that we will move along the continuum of this shared care depending on where the patient is at, but I'm continuously assessing them. We need to have an understanding of the individual's needs and the extent to which patients are able to participate in shared care. So it doesn't mean that we walk in tomorrow saying everybody's going to do shared care. It's that we understand who is able to do this and who can we move along the continuum, or who do we need to support more. And the future does need to focus on developing internationally agreed tools that can facilitate this process so that we know that we're assessing the right elements to make the right decisions. And going back to what Suzanne Kapp and Nick Santamaria showed us, where only 6% had received education and training, I think it's really important for us to emphasize the role of education and training for all involved. And that doesn't just mean the patient, it means the healthcare practitioner themselves, so that they can develop their competence in this model of shared care and know that they can then share their knowledge and understanding with patients so that they themselves then can develop the skills to become more involved in their own shared care as it was. So just to acknowledge that the research and analysis were commissioned and supported by Smith and Nephew and conducted by the Nursery Research and Planning. So thank you very much. And I'll hand over now to Heidi.
Thank you, Zena, for that really interesting presentation and for sharing that research with us all. My presentation this evening is purely experiential. There's limited data, which is a little bit unusual for me, and there is no scientific or qualitative evidence for me to present. This is purely our experience during the pandemic and how we as a team were enabled to work differently, and in particular with regards to virtual consultations and support for our patients. What's interesting for me about the findings from Zena's research is how some of those findings were actually also our experience. So my tissue viability team consists of leg ulcer, lymphedema and tissue viability teams. Our services, in a response to the pandemic from the government guidance, were essentially put on a sort of provide urgent care only list. So we weren't to stop wound care, but not necessarily as a specialism were we to carry on. So for lymphedema and leg ulcer services, some aspects of care were maintained and some were stopped. Well, leg clinics, for instance, and manual lymphatic drainage. So those services did not continue during the pandemic. We also lost access to some clinic sites and even some clinic rooms. And patients who were shielding could not attend clinics, and they therefore needed home visits, which added to the team's workload. Under usual practice, 60% of the referrals that come into the tissue viability service usually come from nursing homes or practice nursing, and they actually really pulled back on wanting face-to-face visits in those settings, so the referral rates dropped. We had, and I think this was fortunate for us, 3 clinicians who were shielding, 1 in each of the 3 teams. And that was a particularly challenging time for them because they felt very redundant and that they were letting their team down. And as most health professionals wanted to really respond to the pandemic, they weren't able to do that as other people were. We were also being asked to support the community nursing teams with their wound and leg ulcer patients because they were being mobilised into new roles and new teams to support prevention of admissions and early discharges. So that whole pandemic response meant that everything was different. And I'm sure that experience is true for a lot of you as well. So the nation and the world found itself in a time of uncertainty and fear, and the NHS and other health systems around the world probably much more so than most. We were the front line. There was no furloughing for us. Despite this, though, the NHS mobilised and quickly. Some services were halted altogether, and some staff from those services were redeployed to support other areas that could not halt their work, such as intensive care and community nursing. So we had speech and language therapists, podiatrists, dietitians coming out and working with our community nurses and delivering community nursing care. Usual barriers to implementation were removed or reduced, and we were given access to tools to enable us to support our patients differently. We weren't unaware of the concept of self or shared care pre-COVID in my area, but traditional ways of working and delivering care to our wound care, leg ulcer and edema patients wasn't something we were looking to move away from just yet. We had other priorities that we needed to sort out. In tissue viability, we did support some nursing home referrals with telephone advice if they didn't meet our referral criteria. And in leg ulcer services, they were starting to use hosiery kits where suitable and reduce some clinic visits. The lymphedema team were only used to providing SOS telephone support and had recently expanded their service contract to include non-cancer patients as well as cancer patients. So that particular cohort was quite new to them, and they were developing that service offer as COVID arrived. Tissue viability and wound care may not have been at the very front, staring COVID in the face, but our patients nevertheless needed their wounds caring for, and many of them were shielding, and as I said, could no longer attend clinics. My particular trust enabled us to continue delivering care to them by not redeploying any of us. And in the tissue viability team, we both, because there was 2 of us and 1 was shielding, had a caseload of some of the more complex community nursing caseload patients, as well as those requiring negative pressure. I have to say, for me, I thoroughly enjoyed the opportunity to get to know a cohort of patients, their families, and their wounds. A relatively unique experience for a community TVN to follow patients and their wounds and see how they respond to the advice that we were providing and the treatment that we were suggesting. What works? What doesn't work? Which dressings do what they say on the tin and which ones did not perform as expected? Really enjoyed it. The leg ulcer team were enabled to work extra hours and also took community nursing leg ulcer patients into their care, and also undertook domiciliary visits where clinics were closed and patients were shielding. The lymphedema team, not usually involved in wound care, as that does not meet their referral criteria, also took some of the community nursing caseload and clinic leg ulcer patients. And many of their own patients no longer wanted to attend clinics or even see the team, even where this was available to them. As I mentioned before, we were, I think, very fortunate to have a clinician in each of the 3 teams shielding at home. It worked strongly in our favour that our services had staff sitting at home who were able to explore the telephone and virtual platforms provided to us. Despite anxiety about their own situation, they were each empowered to lead on the virtual consultation work, so they can now also guide the rest of the team members how to use these platforms too. The lymphedema nurse did not embrace digital technology in the same way, but she was able to support patients via telephone in taking their own measurements, so she could, along with their full assessment, order the most appropriate compression garments for them. I don't think 18 months ago we ever would have imagined enabling patients to measure their own limbs. When we are where we are now, we can wonder why not. But it's important not to minimise the impact of shielding on our staff. Not only, especially early on, as our understanding was less, were they fearful about their own and their families' health risks, they also felt wholly inadequate as a nurse, unable to support patients as they had been used to doing. As they embraced the technologies provided to us, not just for clinical care, but for education provision also, they quickly realised just how valuable they were to our own pandemic response. So within 4 weeks of the pandemic response starting, we were given access to Attend Anywhere, which was a virtual video consultation platform. A couple of other platforms, Acurex and WhatsApp, quickly followed. And our shielders were able to spend time understanding these platforms and how we could best utilise them within our services to support our patients. It became apparent very quickly for many patient populations that this was going to be something that was necessary to implement. We had to think about how to manage the risks within our specialism, such as poor video or photo quality. How can we capture smell? How can we be assured that the quality of our virtual assessment meets the standard we would normally achieve? Would we miss something because we weren't there to see it? As the staff navigated the new technology, they started to be able to recognise when video or telephone consultations would be needed. For lymphedema, as I said, they only ever used the telephone. We grew to understand our ability to support patients to manage some of their own care as we moved through the pandemic. Our partners in industry and our National Wound Care Strategy Programme in England had rapidly produced materials to help patients develop the confidence to manage some of their own wound care and gave clinicians tools to help guide them in doing this, and we utilised those where appropriate. Of course, we also needed to be thinking about reducing face-to-face contacts where possible to reduce COVID spread. Many patients didn't want to see a clinician, and they actually wanted to be enabled to deliver their own care. There have been people pre-pandemic who have embraced being able to manage some or all of their own care, but I'm not sure if we had introduced this pre-pandemic the way we did, the same numbers would have been so positive about it. It most certainly helped them feel like this was something they both wanted and needed to do. A lot of people were also very aware of the pressure on the health service, and they wanted to help reduce that any way they could. So they were not just, we didn't just throw them into this self-care pit. We were offering them a way of supporting them virtually and in a way that we felt supported them and suited them. This supported their confidence to undertake some of their care. For some, it was a change in treatment. For instance, our leg ulcer nurse was able to identify more patients who might be suitable for hosiery kits rather than bandaging, and they could then use the shielding nurse to provide the support that was needed for them with the wound care. Certainly as a team, we all felt this was something to adopt moving forward. So the negatives, I've used negatives for the title of this slide because it's opposite to positives, but these aren't really negatives. They were aspects of this model of delivering care that can slow it down or hinder it at times. The technology wouldn't always work as needed. And of course, it's not suitable for all. Some wound patients clearly need face-to-face care. Given the nature of our patient population, the use of technology isn't always something our older patients are confident with or have the dexterity for. I carried out a C-section wound dehiscence video assessment with the lady herself and her practice nurse, with the lady being able to position and balance her phone in such a way that we could see the wound and I could guide the practice nurse with probing and assessing the wound. This may not have been as easy with an older person, especially at a time when they would not have been able to take another person with them to their appointment who might have been able to manage that technology for them. So all of these changes to ways of delivering healthcare were implemented to reduce unnecessary contact, to reduce COVID spread. This was the driving factor: protect our patients and protect our staff. We've been able to triage referrals earlier and even on some occasions undertake the support and assessment at time of triage. Patients have been assessed sooner than they might have been had they been waiting for a clinic appointment or a visit at home. Travel time, which can make up a large portion of the community specialist nurse's day, especially if you're in a broad rural area, has been filled with patient consultation time. So for some patients moving to supported care, as we preferred to call it, as this felt more like what we were doing rather than sharing or self-care, it was a step-down process. We had many examples we could choose to use, but I chose this one because this man had a sort of blended supported care journey. Originally, his wound was being managed by negative pressure wound therapy with gauze packing. And I don't know how easy you can see that on that photo, but there's a little lip underneath that inferior edge of the wound there. And I think what's interesting about the work that Zena was talking about when she said the patients come with a lot of other things that can impact on their wound, and this gentleman certainly did that. So he came out of hospital, and because we were taking over care from the community nurses to free them up, I took on this man's care, and we were able to spend time understanding his situation and his home support and what his own abilities were. So don't be fooled by this gentleman's young age. He wasn't really that well a man. Once we'd reached a point with his care that we needed to use less gauze in that lip, I was able to move away from the Renesys Go device to a disposable single-use Pico 7 as we were using in our area. And we were able to use it still carry on using the gauze with the Pico 7. But once we were no longer needing to use the gauze at all, we were able to get to a place where the gentleman himself could do the dressing change once a week, and then I could do the other dressing change when we changed the pump the other time of the week. Now, what had been nice about getting to that point is that I'd been with him throughout this little journey, been able to understand his level of intelligence, his ability to want to do this himself as well. and also support him in teaching us. As Zena said, we were taught how to deliver wound care, and I was able to provide this gentleman with that education too. So once we could stop PICO, we were able to move to, I think we used a standard foam silicone dressing, as many of us might do on a wound like this, to take it through to healing. So by that point, he was able to do his own dressing change, and he wouldn't need me at all to change the pump. And he'd got confidence around that. And so we were able to set up a tester video consultation with our tissue viability nurse who was shielding at home, so that he was able to meet her, and then she was able to support him virtually, taking over his own care. And I was able to step out at that point. But he knew that I was still available to come and see him if he needed it. And he also knew that he had 2 clinicians who were communicating about his care. So he felt confident that he was able to take on this care himself. And indeed he did. And he managed to take himself to healing by June. So we were quite pleased with that particular story. He was very obliging to try this out, and there were benefits to both us and him. We visited less, which meant less time on the road for us, and he didn't have to wait in for us. And that was something that Zena also mentioned in her presentation. He also didn't have to get up early for me to get there, because I might want to start my day with him. And because he was dialyzing, he would often get quite tired, and he much preferred to sleep in late. So as Zena mentioned, people like to be able to be in control of their time and when they can change them dressings themselves. He could shower when he preferred, rather than having to shower around the visits with me going in. So it was a very positive experience for him. But it wasn't always smooth running. Again, the technology didn't always work. And on one occasion, our shielding nurse had sent him a video link via text for him to use, but he hadn't actioned that, because this was on one of the days when he was nearly due his dialysis, and he would get very tired on those days. So we did have some issues around the connection. He's quite rural, so he might have poor connectivity sometimes. So moving away from wound care, I thought it might be helpful to hear how the Trust adopted this way of working with agility, and how speeding up the usually slow process of making changes in the NHS supported services to continue during the pandemic. So you can see that our organisation, which provides a wide variety of both children's and adults community services, went from 0 to 1,000 video consultations in the first month, and that was April 2020. And within 6 months, by the end of September, we'd achieved a little over 20,000. The number one service with consultations was the service called PALMS, the Positive Behaviour, Autism, Learning Disability and Mental Health Service. COVID-19 has created much anxiety for this group, and how fantastic that rather than being cut off from services, they were able to be reached out to in a new way. And we're particularly proud that despite the much smaller caseload number and the perceived difficulties in delivering leg ulcer and wound care remotely, our leg ulcer service snuck into the top 20 services using virtual consultations at number 20. So moving forward, we do want to adopt supported care, shared care, helping patients self-manage, using virtual ways of working. Of course, it's not for everyone in tissue viability related services, but it can be used to good effect. We have supported patients to healing virtually. We've carried out mini tissue viability ward rounds in nursing homes. We've undertaken joint visits with practice nurses and community nurses, and even without leaving our desk, and even undertaken single clinician remote assessments with patients themselves. Since September 2020, 50.3% of our patient activity has been via telephone or video. Our challenge moving forward towards adopting and maintaining this is our shielding staff are now back clinically facing, and this is what they like to do most. They want a break from virtually supporting patients and want to be with them face to face. It's someone else's turn to do the remote work, and this is what we need to start planning as we move out of our lockdowns. Each member of staff blending their clinical work with face-to-face and virtual work. We've also discussed about the skill set of those who supported the virtual care during the pandemic and their level of experience already in existence. The lymphedema nurse, for instance, has decades of experience, and she could put this experience to good effect, being able to picture and understand what patients were describing to her because she already had that experience in place. We've started to discuss how our new staff joining the teams can develop that experience needed to undertake assessment virtually and understand those nuances of what the patient is describing if they've had reduced face-to-face visits to support their learning. So that's a challenge for us all moving forward. Those of us involved in introducing virtual consultations have got a level of experience that some staff do not yet have. And we've got to figure out that balance of continuing with our virtual work and at the same time getting the skills developed in our new staff joining our teams. So we're still on this journey of developing this way of supporting our patients with their ability to undertake their own wound care. And whilst this way of working was thrust upon us, now is our time to understand further how we recognise who we can work with in this way and how we develop shared care to ensure safety and patient confidence. So I'd like to thank Zena for her presentation with the research that she's been involved in, and I hope that our experience helps you link those two presentations together. Thank you for listening to me and listening to our journey through the pandemic with shared care, and I'd like to hand back to Alec now to lead us through a Q&A session.
Thank you both. I always find these very, very interesting, but in particular the idea of shared care, because I think maybe over, pre-pandemic, it was sort of talked about sort of self-care, shared care, but it really has become important, hasn't it, over the last, over the last 14 and 15 months. And I think you just mentioned, it's about getting the balance right. It's not about just forever doing shared care for the future, but it's about finding a balance, what works, what needs to be face-to-face, and basically managing with the resources you've got. There's loads of questions coming in, but I've got a couple myself, if you don't mind. We're just going to spend a couple of minutes because I just wrote some things down, and I know we had some that I wanted to ask you before. So my first question was to you, Zena. On looking at your presentation, you mentioned that there's only 6%. I think you said there's only 6%, or only 6% of people received education and training to support self-treatment. So I mean, if that seems ridiculously low. So how would you address this?
That's a very important point, and I think Heidi mentioned it there. I mean, clearly Heidi's presentation showed how education and training was fundamental for everybody involved in this concept. But I just wonder sometimes, is it that if we're not in a situation where, like Heidi has described now in her service, how moving forward they want to really embrace shared care where it's appropriate. So therefore it's sort of something that they know they're actively doing. Whereas, is it just sort of, when I say like a hit and miss, I don't mean that in a negative way, but it's like that we don't, say for example, we moved from a clinic which was inner city to where there was a lot of older people in our clinics, and then we moved to a new hospital which was out in the suburbs where there were a lot of younger people. And the younger people were working, and like Heidi described, they needed to be able to get to work, they needed to do their dressings themselves. Now, we didn't really call it a concept of shared care. Do you know what I mean? It was just more responding to the need that the person needed to do it themselves. Whereas if we had more formally thought of it as a shared care, one might more actively get engaged in the different elements that are required to ensure the patient has the skills to do that, if that makes sense, rather than just saying, oh, okay, Alec needs to do his dressing himself. Okay, Alec, here's what you need to do it. If you feel okay, you think you're okay, and away you go, rather than saying, okay, in this clinic, shared care is a model that we work with, and then doing our education training around that. I think that might be one of the reasons why.
Yeah, I mean, is there anything you want to add to that, Heidi? Sorry, I don't know that you could. I don't know whether anyone saw this at home. I was having a bit of a technical issue here. My mic fell off, and I was just
No.
told about it, so I was just putting it back on. Yeah, Heidi, anything you want to add to that?
No, I agree with everything Zena said there. I think education is important both for the person that wants to deliver their own wound care and for our staff moving forward in how we support them to do that, as well as develop their own skills as clinicians when they might have less face-to-face contact than some of us that have been around a bit longer have had the opportunity of having.
Yeah, I mean, it's an interesting one because sort of education, certainly to clinicians, has certainly gone online, hasn't it, over the last sort of 14 months? And education, just in general, the education sector, whether you're a student in university or school, has gone online. So we found as a business that we've been doing these sort of events and doing many more of them. But I guess it's finding the right support for clinicians and patients, because it's not necessarily, from an educational point of view, it might not necessarily be this. Or this type of education. So what would you say would be the best support for clinicians and patients? What do you think is missing from what we've seen over the last sort of 14 or 15 months? And then to add to that, what is the most valuable? I'll sort of add that to both of you. Start with you, Heidi, if you don't mind.
I think one of the things that was missing for me was that I was aware of something called patient activation measures that were around in some areas, and these were used to help identify people who could get involved in their own care. And that was really missing to us in our wound care population. And we were sort of feeling our way around all the patients that we were seeing to work out who could do what themselves. I mean, I had one lady with a diabetic foot ulcer that I was seeing, for instance, saw her twice a week. Podiatry saw her once a fortnight, and there was no way she could support her own wound care. But there were other things that she could do. She was getting pressure damage on her elbow, so she could manage that, for instance, herself. She could make sure she was preventing that herself. So I think some kind of tool that helps you recognise that actually shared care isn't about them doing the whole caboodle always themselves. It might be about them doing a little bit. Can they manage their diet? Can they manage how they position their feet in the chair? Things like that. And I think a tool that would help us work out that with people and what level they can do, I think that's something I would find useful.
I think, Alec, that what Heidi is saying there, what Heidi said earlier in her presentation, which I thought was really insightful, was the bit about if I'm somebody who's junior and I lack clinical experience, normally I would work with Heidi one-on-one together, and I'm learning from Heidi as I go along, and I'm seeing what Heidi is seeing with my own two eyes. Oh yes, and she's connecting this to this. Now, if I'm remote and I can't do that, I think Heidi hit the nail on the head. And that's like, say, in our university, we have really good simulation center, and sometimes we find with our students it's that in the remote element of it has worked extremely well. Online, blended, synchronized and asynchronized. But what could be missing is just that actual touch, feel, smell. And if I don't have the previous experience that I can close my eyes and imagine it, where do I get that from? And so in that way, like if we were to continue with that, we need to understand that people do need some blended version of it to build the experience in order to feel confident. And it's the same for patients. But having said that, the patient is the one who's been living with their wound all the time. So they're aware of its nuances and its smells and its pain. And when I move my arm this way, it hurts me or whatever. Whereas if I have no experience, I don't know what that feels like. Do you know what I mean? So I think that's really important. And I wouldn't have thought of it in the way that Heidi has mentioned it. And I think that's very important for us to think about, because you don't want people getting stressed and lacking confidence, which means that they will be hesitant because they're afraid, basically. I mean, clinicians,
Yeah, I'm writing a lot of this down as well, so that we can sort of share it with Smith and Nephew. One of the things I just wrote was smell-o-vision, because I think maybe we need to think about that again. So here's a question for you both then, following on from what we've just talked about. So do you think there's anything that industry and suppliers then could do more of, or just do in general, to support shared care? I've seen over the last 14 or 15 months, websites get built, patient flyers and patient leaflets and various events like this, social media channels and things like that, and they're great. But what do you think would work? What do you think that they should be focusing on to support shared care?
Well, if I jump in there, if it's okay, Heidi, sometimes some things that are missing for me, like, is in terms of when you're trying to explain to a patient what now, like for example, Heidi talked about the lady who, okay, she wasn't able to manage the wound, but she was able to manage preventing a pressure ulcer in her elbow, we'll say. Now, say she couldn't really understand what was happening with her elbow. Sometimes having like 3D models or that to be able to show the patient what's actually happening to them can help them to understand, oh, I didn't realize that. Oh, I didn't realize that when I put the weight down on that, it squashes it. Sometimes materials like that can be really, really useful to help the patient to visualize themselves what's happening internally that they can't actually see externally. Because, I mean, it's a bit like cholesterol. None of us really have a clue about our cholesterol levels until something happens. But it's actually meanwhile back at the ranch swimming around in our bodies doing something. So for me, and also if you're training students and other clinicians, those sort of models can be really, really useful, where in a simulated environment, the person is able to actually learn how to do things in a safe way and try to get some experiential learning from that they can then use within their own clinical settings. I don't know what you think, Heidi.
I think that sounds great. Yeah, definitely need more models and things that can help patients understand. I was going to go a little left field with this one, actually, because something I was thinking of is, the level of support that we were given from industry during the pandemic was great, but it also reached a sort of peak point where we were being bombarded a bit, and then it became a burden to work through which was the piece of literature or support that we might want to use. And so we stopped. We just were like, we can't deal with this anymore. So something that I think would be interesting for industry to focus on is the dressings themselves, and how a dressing can be an intuitive dressing that can help the patient understand things, whether it's a dressing that might indicate that maybe there's an infection in the wound, that there's a change in the exudate. Do you know what I mean? Something like that, I think would be
some have been launched,
useful.
Haven't they?
Yeah.
Not a huge amount, but some have been launched. I think self-care it was probably the sort of the earlier term rather than shared care. And self-care really at that time, you can correct me if I'm wrong, I'm not a clinician, but I've been in this industry for long enough to sort of come across these things. Self-care was really sort of restricted to lower limb stuff, wasn't it? It was, wraps and that sort of thing. And then we moved on a bit to shared care and self-care, where we expect the patient to actually do just a bit more. And I love that idea, actually. I really like the idea of interactive dressings. I do wonder as well, and I don't want to say anything wrong here, but I do wonder whether from a shared care model, whether there's an argument that, the whole of industry should come together and just have a single model of what that looks like and support it together. I think, politically that would be very difficult, I'm sure, and logistically it wouldn't be an easy thing to do. But if you're, like you said, if you're getting bombarded with things, if you had sort of one single,
It's not the wrong thing to say, I don't think, Alec, because
I just need to be. I'm careful that I don't want to say anything politically bad here. So I'm just I forget sometimes I'm just talking to two professionals online.
But if you look at the model of healthcare delivery now in Ireland, which talks about sláinte care, which is the future of healthcare delivery, and for once we've had all of the different political parties come together and agree a vision for healthcare, which won't change if a government changes. And in that way, then we can be confident that we can build and grow our health service into this vision that we have, which is mainly about primary care and about keeping people in their homes and etc. So what I'm trying to explain is that your concept is excellent, because if everybody comes together to agree a principle which expands beyond any one individual, you will certainly ensure sustainability of that going forward. And also remember, collectively we can achieve so much more than we can on our own. And I think that's where the wisdom of all the people coming together, like a football team can actually, or a rugby team, can make a big difference.
Yeah, maybe we'll take this conversation offline and see if we can influence sort of change across Ireland and the UK. But I'm very conscious that we've almost run out of time, and we've got a few questions that have come in from the audience. So I do want to get to some of those. So if you're watching at home, please do stay with us, because we are going to come to some of your questions in just a moment. So the first one is from Laura Rourke, and this is, I like the idea of shared care. I think we've just talked about this. Is there a step-by-step guide for them? And I think there's probably many, aren't there? So do you want to Heidi, would you like to take that?
There are a few that companies produce, but also the National Wound Care Strategy Programme in England produced one, which was a helpful leaflet. It's very wordy. I think we need something that can maybe be a bit pictorial for some people, but so there is that out there. They were all launched early on, quickly, and I think now moving forward we can look at them and make them a little bit more user-friendly, maybe.
Okay, thank you for that, Laura. I hope that answers your question. And by the way, as we said, if there's anything that we talk about today where we can find links, we will put links up into the chat section, and also alongside the edited version of this video on our website from tomorrow. Question number 2, this is from Sharon McDermott. Would undertaking a mental capacity assessment and risk assessment be recommended? Hands up if one of you would like to take that. I'm not sure who's best for that.
Probably your experience, Heidi.
Probably, yeah.
Yeah.
Not necessarily, I don't think. I think if we've got a tool, I'll go back to that tool that will help us identify who can do what within their own care, I think that will make it easier. We can assess mental capacity for lots and lots of different things. Have they got the capacity to understand why we want them to move, for instance, or have they got the capacity to manage their own finances? There's different levels of capacity. So if they're of sound mind, if there's no brain or mind injury, then we make an assumption that they've got capacity. We don't test capacity necessarily for everybody. And you would understand their level of understanding, like with my gentleman and a few of our other patients, as you talk to them about taking on their own wound care and you build that relationship with them. I think we were in a privileged position as TVNs and leg ulcer nurses and lymphedema nurses last summer, because we had more time than our community nurses would normally have to understand this. We were not rushing around trying to do 18 insulins in the morning and all the rest of it. We were just seeing a small cohort of patients with wounds. And I felt very privileged to be able to do that. So we could understand their level of ability to do it. I don't know, maybe a risk assessment will come out of it. I think it might create a burden. If we understand their abilities, we can understand what level they can do themselves.
And I suppose as well, Heidi, when you're dealing with people over a long period of time, things can change for that person. If they got sick, things would change. If they improved, then it would change again. So I guess one thing, and we have been talking a lot about it, Heidi, and us in the group, is about not locking somebody into a box and saying that you stay there, like, you know, that's where you're at, because things can change. So it's important for us to be flexible in our approach, but it's really about choosing the right person at the right time, like, you know.
Yeah.
Okay, well, listen, thank you both. I've just been sort of skimming through some of the other questions, and a lot of them, they are different questions. A lot of them are just on the same theme. It's finding out what resources are available. Are there specific guidelines and things? And I think as part of our conversation, we've covered quite a lot of that. So what I'm going to say now is, as always, we will take all of the questions that have come through this evening. We'll put them into a document. We'll share them with Heidi and Zena. We'll get responses for those, and we'll create a lovely PDF which will go alongside the video and the slides if you want to share those with colleagues. And just check whether, if we didn't get through to your question or if we didn't answer your question today, it's just to let you know we will get to it. It just unfortunately won't be tonight live. Zena, Heidi, thank you for a really interesting conversation. You can tell that I'm very interested in the subject, which is why I sort of talk so much about it myself. Thank you very much for joining us. Smith & Nephew, thank you ever so much for supporting this event. And to all of you at home, again, on such a lovely evening, thank you for spending your evening with us. We really, really do appreciate it. We'll be back on Tuesday lunchtime for one of our virtual lunch meetings at 1 o'clock, so please do come and join us for that. Certificate links should be available now. Presentation will be available to download from tomorrow. To all of my team and the team at Mole, thank you again for working. And that is it from us. So have a good evening, everybody. Goodbye.
Thank
Bye-bye.
you. Bye.
Bye. Bye-bye.